Let's just go through the 10-minute version of a 2-hour course. This is kind of my favorite summary slide of prostate cancer. You can use this slide to introduce 10 different topics if you want. When I do a prostatectomy, and this goes to the Anderson pathologist, and Patricia Cadron-Cosa reads all of them, there is no such thing as extraprostatic extension on pathologic Gleason 6. They are all contained. That was part of my comment earlier today about how to diffuse concern about active surveillance. Gleason 6s don't spread if that's the actual diagnosis. It's about 10% EP for Gleason 3 plus 4, and then you see an acceleration of extraprostatic extension in Gleason 4 plus 3 or higher. To me, that drives thinking on a number of strategies. And there's some interesting background. Focal therapy has been around a while. This is a depiction of the nomenclature, and John Ward at our department did focal cryo even before the MRIs were where they were today in multiparametric. And based on pathologic specimen studies, he was doing hockey stick, which is we see the left. So if you have and initially this was 12-core biopsy with unilateral disease. If you were eligible for that, he would treat that side and the anterior half of the other. There's a nice paper from him in the British Journal about the rationale for that. But you could do hemiablation, and not until multiparametric MRI and other ablation techniques do people actually truly do lesion-directed therapy with some sort of described margin of error, so to speak. So what are the key questions? Targeted focal destruction, or as a definition, targeted focal destruction of cancer tissue with the preservation of surrounding healthy parenchyma. That still gives you wide open nomenclature in terms of lesion-directed therapy versus what I would call, hockey stick is really subtotal treatment if you think about it. And what are the endpoints? There's quality of life, there's cancer survival metrics, ADT survival, and other ways you could measure what we're gaining. Most of the literature is on sort of, you define a candidate for focal therapy, then you do a prostatectomy and see how good your selection criteria are. So a lot of that does depend on the accuracy of the imaging, what happens with clinically insignificant versus significant disease. And again, what is the gain relative to definitive therapy or active surveillance? These are mainly the pro arguments that focal therapy is more of a personal or adaptable treatment to the disease and patient rather than just treating everything. It does potentially hit the sweet spot between surveillance and intervention, and there's got to be a population of people in between that. The least controversial topic is that quality of life is clearly better with focal therapy relative to standard therapies. Now, at active surveillance comparisons, that gets a little bit hard to discern, I think. But maybe it will simplify the natural history of the disease, avoiding the transition from active surveillance to intervention, which, if you're on the PROTECT trial, that was half the entire surveillance arm. At Anderson, depending on selection criteria, it's anywhere from 15 to 30%. So could you head that off with some sort of adjuvant therapy, some people have described it. There's a lot of lessons to be learned on randomized trials in the broader context, especially when you think that the pivot trial of surgery versus observation was negative. So then why can't we do something a little bit less toxic, so to speak, on quality of life? And we know that radiation, although has certain advantages to quality of life, there are limitations with the amount of ADT it gets, and you'll see that on the later slide. Gland size, it's really hard. I have a hard time recommending radiation for severe LUTs and obstruction. Now the con of this is MRI is, I think, still estimation more than precision, and I don't even have to prove that because the last speakers have already shown you, the pro and con of MRI, if that's going to be the main way you design and deliver the therapy. There's a lot of disagreement about false negative rates. Mine are about 20 to 23% rate, reference to a transperineal biopsy, not a full saturation like Dave does, but we're getting around 30 cores, more like the guy's technique of sampling top to bottom. Lots of debate about margin of error, multifocal disease, and as Patricia would say if she was debating this, the largest tumor is not always the highest grade. It's often the second tumor. It's rarely third or fourth, but it's not dominant is not always the aggressive one. And I don't know the answer to this, but I keep trying to think through the long-term ramifications. Is monitoring actually easier? I mean, one of the benefits of prostatectomy when I counsel patients is it's fairly easy to monitor it. And in fact, after a couple of years, we usually discharge people and tell them how to monitor their PSA with under 0.1 as their new normal. You don't routinely have to biopsy an RP or routinely image thing, whereas you have to do all of these things on surveillance, and you probably have to do some, if not the similar schedule on focal therapy, repeat biopsies. You're going to have to trend some sort of detectable PSA and interpret that. That's a difference. Now here's the moving target. Is salvage actually straightforward for radical prostatectomy if you're going to do it after focal therapy? The good news is I'm surrounded by 2 laser centers, and salvaging what they do is actually not that hard. That doesn't mean I would encourage them to go get all cowboy and start doing high-grade disease, but it doesn't create a terrible tissue reaction. HIFU probably does, although it probably depends on exactly how much HIFU you applied. Whole gland HIFU is a disaster for an RP, in my opinion. Now, you could certainly salvage them with radiation, or you could repeat the focal therapy, so that's a tough area to debate as well. There's a new Journal of Urology article on this, and this was a stat before that, but at least 20 to 25% of focal therapies at 12 months, have cancer. So I think what I put on the social media tweet for that article for Journal of Urology is it's partial treatment, you get partial efficacy, right? So should it be a first-line therapy? The other one that was in JE that I liked is this Priester paper. I think it was actually UCLA. So, and you have to read the whole thing in the editorial. So according to y'all's paper, 80% of tumor volumes were outside of region of interest boundaries. Now, Mark Emberton went all nuts on y'all and then tried to, it's an uninterpretable editorial, but he tried to convince you that it was under 10%. So maybe the truth is between 80% and less than 10%, depending on which engineer you're working with, I guess. So statements for now, actually hockey stick, according to John Ward's data, looks pretty well, and that's in an extended follow-up, but total lesion direction, you're at the mercy of what your MRI is showing you or not showing you. There's clinical trial registries from Jim Hugh, at least trying to come to agreement on what endpoints should be done. Probably the ideal case selection is intermediate risk. I'll skip a few of these points, but just to note that there's over 80 trials on clinicaltrials.gov last time I looked. And I think I'm going to skip that as well. And just to, before the summary, just to show an example of what I mean by what are we gaining, this green line down here is sort of a multidisciplinary quality of life epic, just the sexual survey. So notice how the most profound decline in sexual function is radiation with androgen deprivation in the early going. Radical prostatectomy is the blue line. But up here, you basically see active surveillance, brachytherapy, and proton monotherapy without AT having sort of a similar slight decline over a 5-year period. So, and the urinary scores are even harder to interpret as to where focal therapy is going to get you a gain. So that's a lot of question marks, but I do think there's a room for it in Gleason 7. As you saw on the test, this is the quiz we did that currently considered experimental. I don't think that means it has to be done at academic centers, but it should be done under protocols. We should learn from our experience as we go because there's so many unanswered questions. I think the greatest feature of this is in Gleason 3+4 with careful imaging. Above that, I think you're playing with fire. We'll stop there. Thank you.